Thank you for that amazing conversation. Wow. I never really thought about those impacts in the small and large business community and how devastating and the ripple effects that they can have. So thank you so much for that really excellent conversation. I have the honor of being a moderator for our last panel today, which is focusing on the human experience with our speakers, Elle Seibert, Dr. Susan Levine, and Lauren Nichols. Do we have our panel on the Zoom? We'll get that pulled up. Oh, beautiful. I see one, I see two. I see three, there we go. Hello all, welcome, welcome. It's so wonderful to see you. So I'll give a quick round of introductions, and then this is going to be a conversational style format, really diving into exactly how COVID impacts the lives of the people it touches with long COVID. And so I think this really caps off our presentations today, because we started off at the very scientific level, really looking at the human body, and then we zoomed out to the economic level with vaccines, and then we looked at the impact on specific industries, and now we're really going to talk about the humans behind all of this. And I think this is a really great way to contextualize everything we've been talking about today. So I'm joined here by Elle Seibert, East Coast origins. Elle moved across the country in pursuit of her studies in neuroscience. During her time at the University of Southern California, Elle developed an absolute love for her interplay between science, philosophy, and the arts. To this end, she enjoys bringing together different kinds of minds to think deeply about the world's most pressing social scientific needs. And Elle serves as the You and Me Registry Data Manager for Solve M.E. Next, we have Lauren Nichols, the Vice President of Body Politic. Lauren is a social justice and chronic illness advocate and a US government manager. She was the first patient within the US to publicly discuss the chronic trajectory of COVID and long COVID, medical gaslighting, as early as March 2020, and is a global leader across social media on long COVID patient outreach and public education since March 2020. Lauren has supported numerous federal long COVID advocacy and policy events and is a patient expert on the NIH Recover Initiative. And last but most certainly not least, Dr. Sue Levine. Hi, Sue. It's good to see you. Dr. Sue Levine is the founder of the, pardon me. Dr. Sue Levine first became intrigued by CFS patients during a fellowship period working with the Dr. Charlotte Cunningham Rundles, one of the co-authors of the original case definition of CFS ME. Dr. Levine examined natural killer cell function abnormalities and response in patients and opened up a private practice to provide medical support to the growing CFS population in New York and New Jersey. Over the last 2 decades, she has collaborated with other clinicians, researchers, and co-authored the Manual for Physicians, a primer for internists in the care of CFS patients, and served as a reviewer for the IOM report, the Institute of Medicine report on ME-CFS. Dr. Levine was formerly the chair of the Federal Advisory Committee for Chronic Fatigue Syndrome, and she remains committed to seeking better patients for CFS ME community and long COVID patients and collaborating with like-minded scientists and gaining an understanding in this illness. Dr. Levine, Elle, Lauren, thank you so much for joining us here today. I'm going to ask to start off with a short description, if 3 minutes or less, if you could each talk a little bit about how long COVID has affected your day-to-day life and your day-to-day practice in your case, Sue. Lauren, would you like to start us off?
Absolutely. So hello, everyone. It's a pleasure to be here, even remotely. Thank you, Emily, for the great introduction. And thank you to Solve M.E and the Global Interdependence Center for hosting this. This is such an important discussion. So that said, I am a long COVID patient. Prior to the COVID pandemic, I was perfectly healthy. I had absolutely no pre-existing conditions other than insomnia, but who doesn't have that in this day and age? And was a very active 32-year-old. I was a trail runner, so on and so forth. Very typical story for a lot of us long COVID patients. And my first symptoms started on March 10th, a day before the WHO declared COVID a global pandemic. And my symptoms were nothing like what the CDC had said. I felt more like I had mononucleosis, dysentery, and walking pneumonia or COPD, all kind of at once. Never felt like I had a common cold. And very quickly I realized, when the 2 weeks passed, I wasn't getting better. I thought that there was something seriously wrong with me, and I thought that I was a rare breed. I didn't really know much about post-viral or post-infectious illness. And so I began speaking out because no one was talking about it. I think the only person at the time, in mid-March at that time, who was speaking about COVID in general, what COVID was like in a body, was Rita Wilson and other celebrities, and I couldn't relate. So I went public with that on March 26th, discussed the medical gaslighting that I experienced. I experienced ageism right off the bat. I was told, you're 32 years old, I'm not going to give you a test. Even if you had COVID, you'll be fine, you'll recover. That was the first time, denied a test. Second time, I was guilted and told, you really think you need this test? You're taking it away from someone that probably needs it more than you, meaning an elderly person at the time. And I knew that I needed it on file because my symptoms were not like what the CDC was saying. So the very long story short is I have been battling long COVID ever since then. My symptoms got worse around week 4. And I did end up developing pneumonia. I ended up having extremely severe GI and neurological issues predominantly at the start. And then when it began to transition into the chronic trajectory for me, that's when it really became more, or at least my immune system seemed to become more involved, more activated. I had a litany of herpetic reactivations. Dr. Levine is actually my remote immunologist, and she is the only person that actually was able to help diagnose these. Prior to that, all of my tests were normal, even though I was not normal, not healthy. I have had everything from eye shingles. I've had eye shingles 4 times, and it's attributed back to my my COVID case. I am not clearing these viral reactivations. I'm slowly going blind in my left eye as a result. Not a fun situation. Even with that, I experienced ageism. A doctor saw dendrites in my eye and said, if my colleagues knew that I was diagnosing a 32-year-old with eye shingles, I would be laughed out of my practice. And because of that, I wasn't given the antivirals in time. And because of that, my body was left to figure it out on its own, which is hard to do when you're in an immunocompromised state. I ended up having a stroke at month 10. And just to sum it all up, I have been very involved in trying to make sure that the patient voices are heard, that the whole litany of symptoms that we're going through, that we're experiencing, are understood, that we're not softening or minimizing this experience, and most importantly, that we're elevating the reality of post-infectious illness, because long COVID clearly is not the first, and it will not be the last. This just happens to be the largest scale mass disabling event in modern history. And unfortunately, we have a society that is unfortunately in ways led by ableism, led by sexism, led by ageism, and we are up against some beasts when it comes to that. But unfortunately, due to the amount of people that are experiencing this, there is a lot of action and change that's needed before things get worse for all of us in this space.
Wow, Lauren, wow. That really touched me. Dr. Levine, since this is your patient, would you like to share next about how long COVID has impacted your practice?
Yeah. Well, first of all, I want to apologize to Lauren because I owe her a phone call. Now, the problem is I wish there were some clones of me, quite honestly. And this was the case for many years, as you said in your introduction, it's actually 30 years, but I don't mind if you say it because it ages me to say 30 years that I've been doing chronic fatigue syndrome, ME/CFS. And, and just like then, the same situation now, there are not enough of us who really, as clinicians, try to understand the illness because it's clearly real. I mean, why would anybody make something like this up? Just because the markers are not so apparent on blood tests doesn't mean that the illness doesn't exist. I guess that's pretty apparent. But so just by background, as you said earlier, I've been dealing with ME/CFS, which there are many, many similarities, but some differences with long COVID. I think, as Lauren alluded to, it really hits you like a ton of bricks. I mean, the dysautonomia, frequently the heart racing, the overwhelming fatigue. Whereas I feel like in general, not in all cases, with ME/CFS, it can be more of a gradual onset. Typically with long COVID, it is more of an acute onset. And I feel like same situation as before, while there's a lot of research going on in laboratories relating to this, as was discussed earlier in the program today, microclotting and some of the other stuff that's being looked at, there really aren't enough clinicians being trained to help patients with the different problems that this causes, neurologists who might deal with the small fiber neuropathy, for instance, and actually prescribe IV gamma globulin and follow through. Sometimes, when you go to some of these, not to put them down at all, the recovery clinics, they do a lot of, exercise, like rehab, and, they acknowledge long COVID, but they don't take that, further step or two that's, I think, so necessary. So I would hope that that would be in our future, that we can train a group of, frontline people to really do something about this illness.
Thank you, Dr. Levine. And Elle, would you like to describe your experience?
Sure, absolutely. First off, thank you, Emily. You are always the most lovely moderator. I'm always happy to be on a call with you. And I'm just thrilled to be joined by a lot of people that I really admire. Lauren, you were one of the earliest voices that I was following on social media. I remember in particular one Clubhouse conversation where I said I was listening in as an ally, but meanwhile, I was actually in the waiting room of the hospital because I was having heart attack-like symptoms at the age of 26. But I'm gonna start from the beginning. The earliest time that I had the inkling that something was wrong in my body was around this time of year, 2 years ago in 2020. I previously had been an extremely active person with seemingly endless energy. I've been biking, playing tennis, swimming, boxing, you name it, my whole life. Energy was never a problem. And so one morning I had been on one of my bike rides up the LA River. I would go as far as 20 or even 25, 30 kilometers, and then go ahead and power through my 8, 9, 10-hour day because I love the work that I do at Solve. However, this time I came back from my bike ride and I fell asleep for about 4 hours in the middle of the day. As Lauren alluded to, many people experience insomnia. I am definitely one of them. I usually have trouble falling asleep at night. So it was very strange to me to be just completely in slumber for 4 hours in the middle of the day. Unfortunately, testing was not broadly available at the time, especially not to people of my age and health status. So I sought out one of the fancy health clinics. I got a subscription at Parsley Health to be able to gain access to antibody testing. And I paid $150 out of pocket to get access to an antibody test. Unfortunately, because of the time window, as we know now, I came back negative. It's also possible that I didn't seroconvert, but these are things we know now that we did not know then. So at the time, I had ruled out COVID-19 as the cause for the symptoms that I was experiencing. Fast forward a couple of months, I was trying to figure out with that same doctor what was going wrong. And my experience with that clinic was that I got extremely extensive blood work done. And there was one result in particular that was so abnormally high that my clinician actually thought the sample had been compromised. That was C4A, which is one marker of inflammation in the body, a sign that your body is fighting something. If my computer screen is moving, it's because my cat likes to join. And so we had retested for this particular marker a couple of months later, and it was still exceedingly high. So my clinician recommended that I get my living space checked for mold. And so I had reported this to my Los Angeles landlord. I did not hear back for 1 month. I did not hear back for 2 months. And ultimately, I ended up spending $600 out of pocket to be able to pay for an air sample on my own. This is no easy cost. The average American doesn't even have $400 or $500 saved. So I like to point this out. So I spent $600 out of pocket to get an air quality sample. And lo and behold, it turned out that there were moderate to high levels of aspergillus in my living space that I was quarantining in during the pandemic. A couple of months later, I sought out the care of my naturopathic doctor who had guided me through autoimmune disease in college. So when I knew that I wasn't receiving support from Western medicine, and she recommended that I get an analysis to see whether those mold spores were found in my body. So I spent another $400 to be able to gain access to a test that could look at the levels of mold in my body. Lo and behold, I had moderate to high levels of aspergillus found in my body. I took this to my landlord with the hope that I was finally proving that something was wrong because they were making me feel like I was absolutely nuts. And the only response I got back was a letter from a lawyer. So I knew that I was completely on my own. I knew that there was no place that I could go to check if a mold remediator was certified. I knew that there was no doctor that I could visit that could offer me a test or guidance or really anything for mold exposure. Nothing at all. Any of the support that I've gotten is the kind of care that you pay for, not the kind of care you're covered for. So I am all too familiar that the validation that I was able to receive and the treatment and supplements that I've been able to receive that enable me to continue working is not available to the average American. And so a lot of my focus in the call today is really looking at the discrepancy between kind of tale of two cities in the US. On one side, COVID can be a frustration and annoyance. On another side, long COVID can completely upend your life. So I'm really thrilled today to get into the broader ecosystem and connecting the dots, because long COVID is not just a healthcare issue, it is a women's issue, it is a care issue, it is a housing issue, it is a labor issue, and it is absolutely, as we discussed earlier, an economic issue. And I can't wait to dive into all of that with you.
Thank you, Elle. That was a great segue into our next question, actually. Thank you for setting that up for me. We've all heard the phrase that no person is an island to describe the interdependence on each other in our communities. So let's take a moment to talk about long COVID and its ripple effects on families, on communities, on people. When one person gets sick, who else and what else is impacted around them, especially the impact on daily living? Lauren, if you'd like to take that.
Absolutely. It's a loaded question. I will try to answer this as concisely as can be. But the reality is, when one person is affected, an entire community becomes affected. And if you are specifically part of marginalized communities where you very much rely on your community for support, for access to resources, all types of resources, even more so that community is affected. But I think at the grander scale, if we're going to kind of zoom out a bit, the reality is society is affected. This is a societal issue. And I think a lot of people forget that, or they think that when an individual is affected, that their small little bubble or their little life is the only thing that really is impacted. But at the end of the day, if you as a person are chronically ill, it doesn't matter what the source of that illness is, whether it's COVID, whether it's Lyme disease, whether it's mononucleosis, whatever it may be, you're infected. You become chronically ill. You don't have either access to resources, or you don't have the expertise or knowledgeable resources to support you. You may not have an employer if you're working, if you're privileged enough to have a job that's able to understand and support your need for reasonable accommodations or an alternative work schedule or whatever it may be in that regard. Then you have a family that may not understand the depth of your pains. They may not be able to relate to you. They may psychologize it. Then you have your children, if you have children, that aren't able to access the same level of resources that other children are able to access because they have a parent that is really in need of, they have a caretaker that is in need of their own caretaker at the end of the day, or can be in need. And then from there, you have the whole societal impact when it comes to our government. If we are all chronically ill, if we're sick, not getting support, getting worse and worse with these debilitating illnesses because there's no treatments, because there's no cure, there's no curiosity into even researching us, let alone recognizing us. From there, you aren't contributing to the economy in the way that I think a lot of people, foolishly think that you are. So you're not able to, you don't have the resources if you've lost your job to go buy groceries, to go shopping, to go contribute to the lovely capitalistic society that we have. And I think from there, I think a lot of people just sort of assume that when you have a chronic illness, your life is only minimally impacted, and the ripple effect is quite small. It's just a little pebble, and the ripple just stays kind of within your immediate household. But the reality is the ripple effect is massive, and actually the ripple gets bigger and bigger as it goes further out. And when you magnify that by millions of people, that ripple effect is tremendous, and it's clearly global, and it reverberates and reverberates until we learn the lesson, until we recognize, research, we spread awareness appropriately, we communicate transparently, and we understand that this is not a me issue, this is a we issue. And right now, and especially during this pandemic, we've seen it with with people's difficulties with wearing a mask and, and the different challenges that come with that. I think a lot of people, specifically in Western society, hold on dearly to this sort of rugged individualism, and it's me, 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 me. But I think that they absolutely forget that, as you said, we are not an island. We are a grain of sand on that island. And there are lots of grains of sand. All of us are these little tiny grains of sand. And if one grain of sand is acting foolishly, selfishly, whatever it may be, and thinking, oh, well, the other grains of sand can do whatever, they don't affect me. The reality is that island is going to disintegrate. And then there is no island anymore. And we are starting to see the ripple effect with what's happening with the economy. And part of that absolutely is just the magnitude of chronic illness and disability that's come out of this pandemic. But there have been millions and millions prior to that have had, have been dealing with chronic illness of a variety of sources that have been also contributing to the fact to this sort of not downfall of society, but the challenges that we're experiencing in society anyway. They've been swept under the rug, and the communities have been ignored, and the communities are ignored. Then the localities are experience problems, and then from there it goes to a huge national issue, which it currently is.
Absolutely. Dr. Levine or Elle, do you have anything you'd like to add to that question?
Well, I think just like, was said, that we live in this sort of invisible illness space because everybody looks pretty good, and people are younger. And, most of the time when regular doctors do laboratory testing on people with long COVID, the results are pretty much normal, except for an occasional blip. So I think we have to change how we think about chronic illness and think of it as kind of, I hate to say it, like a living death for some people. You may look fine, but inside you're just, slowly dying. And again, people don't believe you. You have to spend a lot of time convincing, not only your family, but disability companies, hey, look, I'm really sick. So again, talk about out-of-pocket expenses, spending like, $3,000 on the 2-day cardiopulmonary testing, $6,000 on neurocognitive testing, to just get your employer to believe, or the disability company to believe, that you are ill when you're already feeling rather poorly, to borrow money from your relatives and all that kind of stuff. So I think the idea of destigmatizing chronic illness and becoming aware of that, and having doctors become interested in it. It's not like a sexy field. When you mention to some like medical student who's graduating, hey, do you want to become, not only chronic fatigue doctor, but, deal with chronic as opposed to like being in the emergency room and dealing with emergencies every minute, it's not as appealing. So I think somehow raising the level of palatability as a specialty to young professionals, maybe just emerging from whatever school they're attending, doesn't have to be a doctor, it could be nurse practitioners, and having more of us around to actually take care of the population. That's sort of my concern as I'm aging in myself, and I have to think about who I'm going to pass my patients. I have like 3,000 patients onto. So that's my concern. And, because it's interesting to me too, despite it being difficult. And I think doctors or other professionals who have an interest in research and treating patients side by side are a perfect fit for this kind of specialty.
Absolutely. And Elle, what ripple effects do you see?
I love the way you were describing it, Lauren, as this ripple effect. I tend to think about it as when you have one person who's affected by long COVID. So think more broadly about the figures in the white paper. Long COVID doesn't just affect that one person, it affects everyone in their social ecosystem. It affects their family, partners, children, parents, colleagues, friends, and beyond. And right now we're having this national conversation about family and family values, family planning, abortion rights, and Roe v. Wade. And there seems to be a lot of understanding that social change is something that could threaten families. And I'd actually like to offer an alternative perspective showing that keeping things the way they are is actually something that is very destructive for families. So one conversation we started having earlier in the pandemic, as we started locking down and becoming more isolated in quarantine, is the rise of domestic violence. Studies in journals like the American Journal of Emergency Medicine have reported about a 20% increase in reports of domestic violence. And the reason I'm bringing this up is because domestic violence is actually very intimately linked to financial stress. Financial stress is something that long COVID creates. A number of us have gone into the kind of debt that you will never come back from. I personally spent over $15,000 out of pocket on medical expenses that have enabled me to continue working over the past year. The average American doesn't even have $400 in savings at the beginning of the pandemic, let alone now. The reason why I'm bringing this up is because long COVID is something that is introducing an anomaly into families that I don't think we're equipped to deal with on a cultural level at this idea of the nuclear family. Right? If you think of a lot of the reasons for domestic violence and discord, a lot of that is financial. And as we've seen throughout this entire day and conversation, that long COVID creates financial stress. Dan Grunebaum has covered this very well, looking at medical debt in particular. And they did a poll that said that out of those reporting medical debt, 65% of people had debts exceeding $1,000. And that out of Americans in terms of savings, about 32% of Americans had $500 or less in savings. So if we're looking at the economic impact of this disease, we're also looking at the relational impact. What is the cost of long COVID, not only financially, but to our families? And when we see domestic violence, children are affected by domestic violence. I myself grew up in a home where my father had a stroke when I was 6 years old, and his care, because he had pre-existing conditions, could cost $20,000 to $60,000 a month. My father spent his entire life and career doing venture capitalism on Wall Street. So for a while, we were able to do that. We were able to accommodate that. But I saw the toll that it took on my mother as she would try to alternate having his care in nursing home settings and taking on his care herself. It affected their relationship. It affected what I saw. And ultimately, it led to domestic violence that caused me to move out at 16. I'm bringing this up because there are millions of children around the country who are watching their parents go through something that their parents don't know a way out of. And it's challenging our relationships. It's challenging our relational and family bonds. And these kinds of things are actually looked at in science as ACEs, or adverse childhood experiences. And I'm bringing that up because when a child has over two ACEs, or adverse events, so this can be something like experiencing a car accident, or experiencing a divorce, or perhaps a parent falling ill with long COVID. When children have that many adverse childhood experiences, with a score of 4 or more, the risk for diabetes goes up 1.6-fold. It doubles for cancer and heart disease, and it quadruples for chronic lung disease. This is an immense toll on our healthcare system that I don't think we're aware of, that we're not going to see coming. And so that's why I like connecting the dots on these issues, because if we take an interdisciplinary lens, the way that much of the focus of this conference has done, it helps us predict the future. That's what I like about science, is it helps us understand the patterns from the past so that we can predict the future and prepare ourselves for what's coming, because we cannot afford to ignore long COVID.
We really can't. Oh my goodness. Thank you, Elle, for that really deep insight. I just want to check, Dr. Susan Levine, are you still with us? I know your camera has failed, but can you still hear us?
Yes, I can.
Okay, beautiful. I just wanted to make sure. We'll continue. So the next question is about a critical relationship in your life, the relationship between a person with chronic illness and their doctor. And we actually have that relationship with us today. So I would like to start with, how would you describe the relationship in the doctor's office and what impacts it can make, positive or negative, in the life of a person with long COVID?
Yeah.
Lauren, would you like to kick us off?
Sure, yeah, be happy to. So I will speak first to my experience prior to being introduced to Dr. Levine. I will speak to the dark side, really, of the medical system first. So my experience prior to finding a doctor, one doctor, only doctor, Dr. Levine, supported me. And I'm in Boston. Dr. Levine's in New York City. That's just, and again, this is just to show you the scale of the lack of knowledge that's out there. So I'm located in Boston. supposedly phenomenal healthcare in the area. We've got Mass General, we have research hospitals. I'm not in a rural area. I'm in an area where there is a lot of clinical research being done and supposedly world-class healthcare. Well, I described in my introduction my first real experience with chronic illness and the healthcare system, and my first experience was right off the bat ageism. Immediately after that, and I did find my way. I did get that test, but again, not without guilt, which caused me to have suicidal ideations right at the start. It had me to have immense survivor's remorse. I felt as though I had taken away a test from someone that desperately needed it, and therefore I would have killed that person. This was just sort of the psychological effect of having the medical prejudices and biases that I experienced right off the bat. I also didn't have my symptoms believe, even with that positive test on file, which I needed, and I knew I needed it because I just thought that if I had that test, it would show that these bizarre symptoms I was experiencing were in fact connected to COVID. And because this was, again, I was a healthy person prior to this, and a lot of my symptoms were, for instance, now we know they're connected to COVID. I had COVID toes. I had debilitating migraines of all different types. I forgot how to use a shower door handle. I forgot how to use my toothbrush. I forgot how to speak. I could barely walk. I had extreme GI issues that when I went to the ER to get support for that, they had run different tests on me for different parasites. And I kept saying, this is COVID. COVID causes GI issues. And they looked at me like I had 10 heads and quite literally laughed me out of the ER. And this was while I had blood coming out of my body, very serious GI issues occurring. My experience from there went from I was fortunate to have a primary care doctor who was at least knowledgeable about the term post-viral illness. If it wasn't for her, I would have thought that I was a rarity. And I probably wouldn't have been so vocal and in the news and the mainstream media about my case because I would have felt stigmatized. But because there was a precedent, there was ME/CFS, there's these known conditions, even though the public and the medical profession just simply refuses or has been delayed in acknowledging them, at the very least, there are known conditions out there. So because of that, I did have that one good experience where I had validation early on that I wasn't necessarily crazy, though I did feel that every single time I went to the doctor, simply because every visit that I had prior to meeting Dr. Levine, the first question that was asked to me was, well, you know a lot about your symptoms and you know a lot about the science. It sounds like you're anxious. So my being educated and my being aware somehow meant that I must be an anxious individual. And unfortunately, from there was a lot of medical sexism that came into it. I remember I was desperately waiting for a neurology consult because I was having about 6 migraines a day, every day for about 4 months straight. And it was debilitating. Meanwhile, I have to work. And when I saw that doctor, this was the head of the neurology department at the time at Mass General, again, prestigious institution. We had our appointment, and essentially what they told me was the reason for my chronic migraines was because I was a menstruating female. Mind you, I began menstruating at the age of 9, and I had never had a migraine prior to COVID. And at the time, they weren't connecting neurological issues to COVID. We now know it's very much connected. It's a neuroimmune issue. There are neuroimmune issues occurring. And so my experience prior to was really that, I guess my introduction to chronic illness was also my introduction to the failings of the medical system. I always thought that as a healthy individual, that medicine could save me, that all I needed was a good doctor, and any doctor would champion for their patient and they would do everything they could to help you. But what I actually realized was the sicker you were and the less visible your symptoms were, and if you fit certain demographic profiles, BIPOC, female, LGBTQIA included, that you are almost instantly psychologized. So the sicker you are and the more help you need, if you fit these certain categories, and this obviously, I'm stereotyping here, but I will say this has been my experience with every single medical professional, with the exception of Dr. Levine, again in Boston, has been that the sicker we are, I think the more complicated of a case we become, and the more complicated we are, the more that the egoism of the medical profession steps in, and the less that they're willing to help, the less, they know we're a harder egg to crack, so they don't even want to attempt to be curious. They don't want to attempt to try to support, because I think it makes them feel small in ways. And I think there's also a level of guilt on their end where they can't support. It also doesn't help that insurance requires for some practitioners, 15-minute appointments, and you can't really accomplish much in those very short appointments when you have chronic illness. And there's a whole litany of issues that you need to discuss and really talk through, and come up with a plan for. So I think, so prior to meeting Dr. Levine, that was really my experience with the medical system. Since meeting Dr. Levine, again, once I received those more molecular level tests that were looking deeper, because gross medicine and the standard tests that are out there are not holistically supportive for us chronic illness patients, where we're still trying to figure out root cause, pathophysiology. But it wasn't until after I got those tests from Dr. Levine that I felt a sense of relief, a sense of actually being recognized, having a medical professional with years of experience say, and without saying the words, "You're not crazy. This is what your blood is showing. This is the story it's telling, and I'm here to listen to that story and to see what we can do to mitigate." And with that, with the results that Dr. Levine actually, with the test that she ran, that is the only way that I have made any success, any progress with my local practitioners. With those tests in hands, I have asked them, I said, "Look at these levels. Do not tell me that I'm a healthy individual." And they'll look at them and say, "Well, I have to research what those levels mean because I'm not sure. I can see that they're off, but I have to research." And the issue right now I find is that they're becoming more aware, but as Dr. Levine said, the education is not there. And I think it falls flat there. They know that there's an issue. They can see with the blood test that we get that there's clearly something wrong. But there is a lack of curiosity, and there is still the biases at play, which affect our ability to get the proper care right now.
Wow. Well, Dr. Levine, you're clearly having a very positive influence on your patients' lives. So could you speak to a little bit about how you develop that influence? Like what, as a medical professional, leads you to have such a strong relationship in the positive sense with your patients?
Well, look, I try. I mean, there are obviously instances where I fall short of that. And I do feel badly about it. I really try as best I can, because it is, as Lauren said, it's very complex. A 15-minute appointment really won't do it. There are so many pieces of the jigsaw puzzle, I like to call it. The way I kind of handle, just to give you an idea, when I see a new patient, I mean, obviously sometimes I get some information in advance of seeing the patient, but I clinically, it's not that hard to make the diagnosis of post-COVID or ME/CFS. The key things, as you know very well, is the post-exertional fatigue, unrefreshing sleep, and the cognitive and or the dysautonomia stuff, the rapid heart rate, they're standing in the shower and their heart's beating out of their chest, or the severe migraine headaches. And like within like a couple of minutes, clinically, I can say, yes, I think you have. And I usually tell them that. And then I said, okay, but let's refine it. Let's do the blood test to look for targets for treatment. So in a way, I don't really need the lab so much to make the diagnosis, but to kind of confirm it perhaps, and then to tell give the patient direction in terms of where to go. To speak, and then I kind of laugh, but I have like 4 specialists in New York that I refer patients to: a neurologist that knows something about small fiber neuropathy, the POT specialist, the rheumatologist that knows a little bit about EDS, and then someone else who does more like mast cell stuff. So I try to channel the patients into those doctors. It's a shame that these other doctors get overloaded, but you have to send people to doctors where the patient feels validated and they're actually going to do something, and you don't waste their time and so forth. So, but I think, it's kind of a problem, because if there are just so few doctors interested in this thing, I've always kind of believed I don't know, maybe I'm naive, but I couldn't imagine that somebody would be making these things up, and I have heard stories about the ageism, sexism thing, which is terrible. But, yeah, I mean, I think ideally what I would love, and I don't know if it's going to happen in my career lifetime, is a multidisciplinary clinic where you have like 6 or 7 specialists that are relevant to this illness, all under one roof. And then once or twice a week, we come together at a table and discuss our more challenging cases. and we'd all learn from each other, and there would be a private lab upstairs that, like a research grade lab, because, we have like LabCorp and Quest, which we worry about, they don't do the more advanced testing that we're talking, like the microbiome testing, as I think Elle referred to. She had to spend money out of pocket, not only for fancy doctors, but for some of the tests that are not in, like the laboratories that are not covered by insurance, to look at, for instance, stool, the dysbiosis, and do you know what I mean? So I'd love to have more resources and more of a multidisciplinary group of clinicians, and like I say, learn from each other.
It's a beautiful vision. Excuse me. Elle, tell us a little bit about how the medical relationships you've had have impacted your health.
Absolutely. So I'm going to start by saying that there are doctors out there who actually work through a multidisciplinary lens. So I applaud my naturopathic doctor for that, but I'm going to put that on hold for a second and share the story of how I got to her. So when I was in college, I started experiencing health issues that had fatigue elements. It was very confusing. I didn't know what was going on, but I did know that I had a family history of a few things. So I started with those specialists. I sought out those specialists. I got blood work, and the blood work came back. They said, oh, your antibodies, they're a little bit high here for an autoimmune condition, but just come back in a few years, i.e. come back when the organ's been destroyed, and then we can help you. No support in the meantime, no recognition. I was very, very quickly disillusioned with our healthcare system right there. So I was fortunate that through my college, there had been a health fair, and one of the booths in that fair was my naturopathic doctor. But it took months and months to get an appointment with her. So I kind of held on tight in that meantime. And I just remember my first appointment with her was about 1.5 hours. She sat with me and talked through my background. She talked through my current relationships and stress and allostatic load, one measure of stress physiologically. She talked through symptoms. She talked through how she approaches her practice. And we really got to have a long conversation where I had never felt so seen and heard by a doctor. And so in that way, I kind of joke that she's ruined me for other doctors because she has. The reason I like her work so much is because she is looking at each symptom that I would have, even if there would be a dominant system, like this is an endocrine issue, this is a cardiology issue. She would kind of take the approach of, in more philosophical terms, that a butterfly shaking their wings halfway across the world can start an earthquake or hurricane on the other half. That issues in one part of your body really are interconnected with other systems in your body. And we can't act like that's not the case. And so she had, with her training as a naturopathic doctor, as an ND, which is very much legitimized, certified, all of those lovely things, she was able to take a multi-system perspective to what was going on in my body. She was able to run the testing at the intracellular level that was needed to give me a diagnosis. And through a combination of diet, supplements, reduction in stress, I am actually currently in remission for that autoimmune disorder. And when I tell doctors that, when I navigate now long COVID and I say, oh, I'm in remission for an autoimmune disorder, they look at me like I have two heads, because in their world, remission doesn't happen for that disease. Except it does. It's just that her care costs thousands of dollars. And it was only because of family help and support at that time that I was able to afford that. I wish that the average American could gain access to the level of care that I got, because it gave me my life back. And even now, with the mold exposure that she describes as contributing to my long COVID, or as a possible reason for why my body was not able to clear this virus, she is the reason I am able to continue working in this capacity today. It shouldn't be that her level of care is only available to people who can get on a flight to see a doctor. She sees patients from around the world who fly into Los Angeles to see her. Everyone should be able to afford that level of care.
Hear, hear. So I'm going to deviate from our prepared questions and take one from the audience. So we've really talked about how there are so few post-infection illness doctors available. Dr. Susan Levine being one of some of the experts, and a handful in this country. So since there were so few specialists, before the pandemic. And now we have a flood of post-infection illnesses as a result of long COVID. Can you address how do we tackle the shortage of trained medical professionals, and how has that impacted your journeys? Again, Lauren, if you'd like to start.
Yeah, so okay, sorry about that. I didn't realize it was for me. So I think for me, the shortage has meant that I have gone through, similar to what Elle had said. So I work for the US government. I'm lucky, I'm very privileged with that. And federal health insurance is supposedly one of the best types of insurance you can get. Even with that, I have spent over $20,000 out of pocket for a variety of specialists, for a variety of different procedures and tests. I will tell you that it took a while to get into the Mass General Long COVID clinic. What should have been a $40 visit for, it was a telemedicine appointment, $705 for that appointment with my insurance. And that's criminal, absolutely criminal. So what I have to say is I think my experience with that has really been that I have honestly probably seen over 50 doctors over the past 2 years, multiple appointments, because I like to give people the benefit of the doubt unless they have right out offended me, like saying that my migraines are from my menstruation. We're not going to waste a cent more on that individual. But what I would say is that I think the lack of expertise in this area, the lack of education at the medical school level, the lack of accessible tests, the lack of knowledge about tests that even are accessible, the doctors just simply don't know they exist or understand how to read them. It causes a significant burden on the patient because we get to a certain point where we lose complete trust in the medical field. And like Elle, I have actually gone towards Eastern medicine, specifically Chinese traditional medicine and herbalism. And that's the only thing that's been helping me. Again, that's all out of pocket though. And I think that if we did have practitioners within the country, ideally globally, that really took the time, had the ability to have more time to speak with patients, really was invested in the research side, was knowledgeable about the latest findings within the space of post-infectious illness, I think that what we would find is that us patients would have a much healthier relationship with our medical providers. I do think to a certain extent there would be more healing in that space. I think at least from a psychological standpoint, I think we wouldn't have the medical traumas that we experience, which unfortunately do exacerbate our physical illness for many reasons. We tend to shy away from going to providers. I for a while went months without having any medical care simply because I felt so shell-shocked from it. And I did get sicker, and I did have flares of shingles in my eye again. And I think that, if there were professionals, and like what Dr. Levine had said, if there was this sort of an integrative approach where I think what long COVID clinics are trying to be, but failing to be, these centers where there are specialists who are actually knowledgeable and involved in research regarding these post-infectious illnesses, I think that there would be a lot more healing happening. I think there would be, ideally, there would hopefully be less cost to patients, both emotionally, fiscally, and everything, because it'd be really a one-stop shop. But I think what needs to happen first is we need to first recognize that there's a problem. And I think a lot of providers just simply refuse to recognize it. And that is really the biggest hurdle. And I think the other part of it too is our government is complicit in all of this. They're a chronic condition. I mean, look at cancer, right? There's, not saying that we need to have a cure for cancer now. We should have had this by now. But even the curiosity into certain cancers and the clinical research into it does still fall flat. And when it comes to post-infectious illnesses, Dr. Levine is one of 12 in the US that's doing any sort of research, clinical research. So I think from my perspective, I think our government at the end of the day is their lack of addressing this, their lack of making this a priority, implementing these sort of policies in place so that medical schools, hospitals have training in place, that there's a wing that's dedicated to chronic conditions and post-infectious conditions in particular. I think, there's a trickle down that has to happen. And unfortunately, I think our biggest hurdle right now in achieving all of this is simply that we still are being psychologized, even though there's very clearly physiological issues happening with all of us. I had a hole in my cornea. I mean, that's not caused by anxiety. and I think that there's biases that we need to work on first before any of this can happen. Once we can work on that, I think we'll be in a better spot. But yeah, the lack of having specialized care in this space, it harms us. It harms us all. But I would say that it has absolutely made me just completely distrust our medical system, and it's unfortunately affected my health in ways that have unfortunately made this debilitating illness even more debilitating for me.
So sorry to hear that, Lauren. And Dr. Levine, we joked about cloning you. I mean, if we had the technology, we would. But outside of cloning 500 of you and setting up practices all over the country, how do you see being on the front lines of expanding our capacity to treat post-infection illness patients?
Right. Well, I mean, one of the baby steps I'm taking, for instance, is I have a couple of medical students who are shadowing me right now through Zoom. So it's in a way semi-positive thing about the pandemic. In a way, I think I have actually slightly more access to patients around the country by, doing Zoom calls and other virtual ways of interacting with patients. And we have like a teaching session where I can have 2 or 3 students on with me at the same time. And I mean, I think Cindy Bateman's clinic, for instance, is doing that on a bigger scale, where, very actively, I think there's a movement towards actively training the younger generation of clinicians, because that's really the only way we're going to do it, and making them feel excited about the field, because it is interesting, from a career, my perspective. I can certainly understand the patients need it, but, you have to get the doctors kind of interested in it too. I think a lot of doctors are put off too, because often you don't cure the patient. Obviously, you're just, and then the patient comes back, oh, doc, I don't feel, you had me on this for a month and I don't feel any better. And like some doctors would be like, okay, well, there's nothing I can do for you. But you have to have the kind of doctor that's just going to hang in there with the patient, and that kind of stick-to-itiveness, which I guess I've learned over the years, to not abandon the patient if the person doesn't immediately get miraculously better. And unfortunately, that is the case with a lot of these post-viral illnesses, because they're so complicated that there's probably more than one solution, or the patient has to be on multiple different therapies and so forth. So that aspect of it has to be understood, as opposed to treating like high blood pressure or diabetes. It's a sort of an easier deal. So I think, but I think, and I think there is more publicity about it. There's, New York Times articles, and, I'm hopeful that, adding the name long COVID, I hate to say it that way, but as opposed to MECFS, which was like for years, decades in obscurity, I think it's elevating it somewhat to a place where people recognize it more and have some sympathy. So yeah, I'm hopeful.
And Elle, as someone who works in research, would you like to talk to you a little bit about how the clinical and research can merge to help increase that capacity?
I think a lot of that really comes down to who you have at the table, because at the end of the day, you can educate yourself about health issues affecting women, or social conditions for BIPOC communities or LGBT communities. And you can educate yourself all day long about how social factors play into the etiology and persistence of disease. But none of that will ever compare to having a person from that community at that research meeting. Because there's examples that I like to think of, and this is why I didn't go immediately into academia, which is that sometimes you'll have research studies that come out with this bombastic result about, oh my goodness, having parks and green areas in urban neighborhoods decreases crime. Yes, if you walked on the street and you talked to someone in that community, they could have told you that in 5 minutes, but no one asked them. You'll have all of these very intelligent and bright people who are in their ivory tower of academia who don't seek out the opinions and the expertise of the communities they claim to serve. We need to be doing that, not just once, not just in a focus group, but on an ongoing basis. For instance, one example I like to use in our research team meetings is how within the long COVID space, I haven't been as much of a public facing figure, but I've been a fly on the wall and I've been listening on social media channels, on Instagram, on Twitter. And around October, I started to notice that my functional capacity was just going downhill and it was freaking me out. So when I went on social media, I actually saw that ME/CFS advocates had a name for this. They called it the October slide. And I started to hear more and more people talk about this. And I kind of thought to myself, okay, well, that's really interesting. What can this tell us about ME/CFS and long COVID? And so one of the first things I thought about was seasonal depression. The changing of the seasons can actually cause physiological changes in people's body that change their sleep-wake cycle, that change their mood, that change the foods they crave. This is very deeply rooted in not only human history, but mammals in general. Bears hibernate in the winter, right? Those are certain circadian changes that we can understand. So to wrap it up, I'm thinking, okay, well, is there a circadian component? What if a lab like the Huberman lab at Stanford were to do a research study that's looking at circadian rhythms in ME/CFS? That could be a fascinating study that might not yield a treatment, but it could help people with ME/CFS and long COVID plan with their workforce, with their workplace, excuse me, and to be able to say, hey, I know what's coming. Now we're going to prepare for it. I might work a reduced schedule during those months, et cetera, rather than just going into it blindly, not knowing what's going on in your body, why you're getting worse, or if you'll get better. And all of this came from listening to patient advocates post about their experience online. Imagine how much more we could do if they were actually in the room at these meetings.
Well, we have some patients here today. Thank you all for joining us. And we have many more watching online. So we have just a few minutes left, and I'd like to focus on something we haven't talked about it yet at all on this conference, which is media coverage. There's a lot of stories and conversation about long COVID in the mainstream media. And for the people in this call who are the front line, are they getting it right? As individuals living and caring for people with long COVID, what are the biggest successes or failures that you see in the current media conversation around long COVID? And Lauren, I'm going to pick on you first again.
Yeah, so this is, I'll try to make this as short as can be. It's a loaded question. But the answer is no, they're not getting it right. I think some of them are trying their hardest to center the patient voice, to ensure that they're being mindful of the terms that we as a community prefer to be called by, because that is important as well. But there are many others that simply don't have the empathy or the awareness or even the interest to really get to know the people, the community that they're trying to educate others about. And I think that two issues that I have seen perpetually in working with the media over the past 2 years is that there is obviously there can be some sensationalism that's part of it. And sometimes what will happen, and I say this as a patient who has been interviewed for numerous stories on long COVID, the sexy stuff may not necessarily be what the patient is wanting to get across, but that is what the reporters, what the journalists will focus on. So for instance, a huge issue, and one area that I have been desperately trying to get the media and others to be aware of, is the reproductive issues when it comes to long COVID, specifically about the female population. No one is talking about it, and it is a crime against humanity. And when I have interviewed individuals and we have discussed the various challenges that face the long COVID community, what they'll do instead is they'll pick little bits of what I have shared about other needs, such as government funding, education programs for clinicians. They'll pick these other areas that maybe are less polarizing, or they side more with it, whatever it may be. And they will not focus on the matters that are truly at the heart, the most important matters. Even when you stress that these are the most important things, they will pick and choose what they share, and they will kind of go for this more either the sensationalism, or they'll go for more of interest piece that they wish to choose. They won't accurately reflect the patient voice, and that's a problem, because what they're doing when they do that is they're choosing what to share about the community. And it is not up to any reporter to siphon. If they truly want to explain and give transparency to what is happening, they need to set aside their own thoughts, their own interest, and just let the patient speak to the story. Let the patient explain what the community level issues are, what their personal issues are. So that's one issue. I think the other side of what I have noticed that's been happening in media is that there is a lot of, and especially at the beginning, I was the first patient in the US to come forward in mainstream media to talk about the linger effects of long COVID. I am a white female, and it was difficult as a female. I did face a lot of horrible sexism from just coming forward in the media. I was given death threats. I was told I was a paid actor by the government just by speaking out, trying to raise awareness. But what I have to say is that when I began advocating more, I tried to get more BIPOC long COVID patients to be part of that discussion, to be in the media, and it was a battle. They didn't want to share that. And I think that is a huge disgrace, because we know that the BIPOC communities are disproportionately affected by COVID, by long COVID. They don't have the same access to care, if at all. It's a tremendous issue, and many reporters have turned away from speaking to these communities, despite persistently trying to get them to do so. So I think there is, again, I hate to harp on this whole bias-y issue, but there are a lot of biases that are in place that really impact our ability to transparently discuss the issues at hand in the community. There's many more, but I'll leave it just at that.
Appreciate it. Thank you. And Dr. Susan Levine, any thoughts about the media coverage of long COVID?
Yeah, well, I was just thinking as Lauren was talking, and I agree with all that she said. I think, unfortunately, the media comes after you generally when there's a new finding or, something sexy or interesting, and because they have to please their readers and their editors. And so you're right, the more things that they consider to be sexy and exciting come out on the, but I think what I would like to see, at least, is the like a New York Times magazine piece that might go into like in the one day in the life of a patient, because sometimes, like, the daily newspaper, unfortunately doesn't have the time or the space to go into that type of thing that I think is so important, but that maybe a different, or like somebody that recently interviewed me did a podcast. The Wall Street Journal does these podcasts, and like other little media opportunities to maybe do a profile on somebody, which I think would be great. But I think like the ordinary newspaper that we're used to reading, sort of, unfortunately, it's going to be those bullet points that aren't going to tell the human side that much. But yeah, I would hope there would be more of that, more in-depth stories, because I think they tell so much about not only the patient, but about his or her interactions with the family and other people.
Those ripple effects we were talking about.
Mm-hmm.
Elle, you have the last 3 minutes. What do you think about long COVID in the media? Are they getting it right?
I think I'll have to give the Spark Notes version of my response. And I'd have to say that, like the others, no, absolutely not. I think there are 2 reasons for this. One of them being that since the beginning of the pandemic, when patient advocates like Lauren have been speaking out, long COVID should have been included in every single conversation, every single newscast, every single politician speaking about COVID should have been speaking about long COVID. Because for people my age, we were told that there are 2 paths out of COVID. You survive or you die. We were never told about the 3rd path, which is potentially lifelong disability that none of our systems are really prepared for, especially for people our age. And so that's kind of right off the bat, long COVID should have been included in every story about COVID. But number 2, I think it's our hyper focus on COVID as an individual topic, because especially now, over 2 years into the pandemic, people are exhausted. Our, mental health capacity, our emotional capacity, our capacity for empathy, and we're drained. So a lot of people, especially, people my age, have been tuning out COVID news because we don't have the mental health resources to dial into that news. I myself, I usually read the New York Times every single week. I am 7 weeks behind on the Times because I just don't have space for it right now. And so the reason I'm bringing that up is because really long COVID touches so many other sectors. Long COVID touches, there's artists with long COVID. There's a group I like to reference, Black disabled creatives, as a resource. If you are seeking out freelance work, you can reach out through Black disabled creatives. You can interview a cook with long COVID about how long COVID has affected their cooking. You can look at long COVID from dating and relationships and talking about how, like, things that you do in that context, things like, I'm not forgetting every personal detail that you're telling me. I have cognitive issues. I'm going to forget things. And it doesn't mean that I don't care about you or I don't like you, right? Like, there are different aspects of our life that are so much richer that people can connect to once they've dialed out of the COVID-19 topic stream. So it's about meeting people where they are. If you like art, there's an artist with long COVID. If you like travel, there's many patient advocates talking about traveling with chronic illness. We've got to get into other sectors outside of just healthcare and COVID-19, so we can reach people where they are and with what resonates with them.
Absolutely. On that note, we're going to round out this panel. Ladies, thank you so much for this conversation. I am so grateful to you for your time and sharing your experiences. Thank you. Thank you. And thank you everybody online for joining us. We have our final remarks just to wrap us up today from Bill Kennedy to leave us with our final thoughts.
Emily, you did such a good job of emceeing, you lost your voice. So well done. Thank you. So we had a promise today. That promise was enough ideas that we could find at least one to take back to our families, our businesses, and our communities. I would say we have achieved that promise in multitude. So Ovid, thank you very much for your leadership and putting this together. It's been a fascinating day, sharing opportunities and to learn something new about long COVID. I have been stimulated by the conversations, the questions that have come from here in the room and from people online, and certainly from our panelists. I think one of my takeaways is that long COVID is not going away. Well, we aren't either. So to that end, I just wanted to highlight our next program in the series being co-hosted by Long COVID Initiative and GIC. That's coming up on June the 7th. The topic is Long COVID and Children. It's a virtual event, and that's going to be June 7th at 2 p.m. Eastern. Again, June 7th at 2 p.m. Eastern, and the registration for that is now open at www.interdependence.org. I got that right, Jill. Okay, thank you. I do want to recognize Jill Fernito, our Executive Director from the GIC. Thank you. Colleen Murphy, and Siona Aurora, also from the GIC. Ovid and Emily and all the staff from Solve M.E. Thank you for hosting this. What a great event, and I'm really looking forward to the next one. I think based on the feedback that we've had thus far, ready for number 2. So, in closing, I'm glad you're here. I think your presence has shown a commitment to raise the awareness around this very important issue, to help be social stewards around long COVID, and for that reason, I salute you.